Good afternoon, everyone. I'm sorry I'm not with you in person, but unfortunately, I'm out of town. Each year since Matter opened, we've been honored to work with the Consulate to support promising Canadian entrepreneurs building next generation technologies. We help them with their U.S. entry and growth strategies, everything from regulatory support to figuring out who's going to pay for their technologies to how to take their solutions to market. For those of you who aren't familiar with Matter, we're a healthcare technology incubator and innovation hub with a mission to accelerate the pace of change of healthcare. We do that in three ways. We accelerate the growth of startups. Since we opened in 2015, we've worked with more than 800 companies that have collectively raised almost $5 billion to fuel their growth. We work with large organizations such as health systems and life sciences companies and payers to help them achieve their innovation goals. Last year, we built and ran 8 cohort-based accelerators together with our industry partners, and this year we're on pace to do 10. We work with the healthcare community to supply provocative content and ideas through a series of programs and events that are open to the public. Up next on the 21st is a conversation with the CEO of Cordis, the cardiovascular company that was previously a part of J&J and Cardinal Health. In a few minutes, you'll hear from 5 terrific Canadian entrepreneurs that we selected this year together with the team at the Consulate. And I am grateful for the support of Acting Consul General Samir Ahmed, as well as Julian Rosen and Corey Olashansky, who we've worked with on this program. The instigator of this relationship and the C2MP program is Dr. Steve Gould. He's been a Matter board member since the beginning. He serves as consulting director for Polsky Science Ventures at the University of Chicago, and he's always an incredible mentor for countless healthcare startups. He was previously chief of surgery at Michael Reese Hospital, and he founded a company called Northfield Labs, which developed an artificial blood product. Again, I'm sorry I'm unable to be with you. I know it will be a terrific program, especially since you're in the hands of someone named Steve.
Well, with that intro, how can I fail? So welcome everybody. Oh my goodness, it's nice to see the room filling up. So this is the first time we've done this since February of 2020, right? Right. This is the 9th year for this program, but February of 2020, really just before the entire world went into shutdown. So welcome back everybody. Thank you for coming. We're going to have a great night. I'm going to do some intros. I want to correct one thing Steve said. The real instigator was Chantal Glass. Where are you, Chantal? Stand up. So I was hoping she would come tonight, and I saw her downstairs. So I'm going to add something to my opening words, which are very short. So the predecessor to the PointB program, it was called Chicago Innovation Mentors, or CIM. And it was in September of 2013, I think, actually, when I was on a panel at a meeting in Skokie at the what is now the Illinois Science and Technology Park. And I was talking about this program, CIM. And at the end of the program, Chantal came up and introduced herself to me. We hadn't known each other. And she said, I work with the Consulate General. I'm in charge of life sciences, and I'd like to talk about starting a program. And we started plotting, but it was her idea. And a bunch of folks said, no, you won't never be able to pull this off. So that only stirred us on. And the first meeting, not only is it the 9th year, what some of you, probably most of you don't know, is we were the first program when Matter opened. So Matter opened in February of 2015. I was part of the founding board, as Steve mentioned. I think we opened on a Tuesday, and then it was the following that Wednesday, if I have my days right. Whatever day we opened, the next day in this room was the first formal opening event at Matter, and it's been getting better and better ever since. So welcome, Chantal. With that, I want to also thank Samir, thank Julian and Corey for their help in organizing this program. I'm going to introduce Samir to say a few words, and then I'm going to go over the ground rules, and then we'll get into the fun. So, Samir?
Thank you, Steve. You said that I'm going to say a few words, but I'm a diplomat, so we don't we're voluminous when it comes to words. So, well, thank you very much for the introduction and for the warm welcome. It's a pleasure to join you all in person today to welcome the 5 Canadian companies selected to participate in this, the 9th annual Canada Chicago Mentoring Program, C2MP, as we call it. This pitch day in partnership with PointB MATTER is a red letter day for us at the Consulate General of Canada. The Consulate General of Canada in Chicago is currently celebrating our 75th anniversary. We opened on the 3rd of November 1947. It shows our commitment, our diplomatic presence in the Midwest, and this is an occasion for us to reflect on the past, to celebrate the present, and look forward to the bright future of Canada-US relations here in the region and beyond. The consulate has a long history of delivering programs such as C2MP. We look forward to building on the momentum of the last 8 years of the program, and we're extremely grateful for the relationship we have built with MATTER, who is well known and respected as one of the leading healthcare incubators and accelerators in North America. I'd like to offer my congratulations to Careteam, Cerebra, Fluid Biomed, HealthEMe and Mikata, who were selected from a pool of over 30 Canadian applicants by PointB's vetting committee. This year's cohort is breaking boundaries with their innovations in key healthcare areas, including virtual care, sleep medicine, treating brain aneurysms, mental health, and medical appointment scheduling. This time, I'd like to recognize other consulate staff who work closely with Canadian life sciences companies each year, including our Investment and Innovation Unit Lead, Trade Commissioner Corey Oleshansky, and Julian Rosen, our Senior Trade Officer responsible for the life sciences and health industry sector, as well as my colleagues. Sydney Salvadori is also in the room. Sydney covers the advanced manufacturing and industrial machinery space, but there's crossovers into the medical devices sector there as well. And Sunita Anand, I believe, is also in the room. There she is, Sunita. And of course, Chantal Glass. Even though you've retired, you're always a part of our team, and congratulations. Yes. Please also join me in welcoming our new recently arrived colleague, Mr. Bin Lau. Is Bin in the room? There he is, indeed. Bin represents the government of Alberta, who've recently opened an office here in Chicago at the consulate to represent the province of Alberta in the US Midwest. So congratulations and welcome, Bin. With Canada's emphasis on progressive and inclusive trade, supporting small and medium enterprises, as well as those owned or led by women and minorities, we are pleased to have a representative group in this program once again from across Canada. Post-pandemics, the challenges facing the healthcare system are still immense, and we would like to acknowledge the dedication and hard work of frontline healthcare workers across the United States and Canada. And for you as innovators in the life sciences and health industries, your work is particularly meaningful as you strive to introduce solutions that will change healthcare delivery for the better and improve patient outcomes going forward. We recognize the work that Canadian companies and important partners in Chicago like MATTER are undertaking to advance the healthcare industry at such a critical time. The Government of Canada will continue to work collaboratively with our partners in Canada and abroad to advance key priorities. We are focused on strengthening the crucial value chains between Canada and the US, the single largest trading relationship in the world. Pursuing global relationships and creating strategic alliances are essential to the growth of both economies. And we, the Government of Canada, is committed to supporting Canadian firms in the development and commercialization of their technologies with their US partners. At the Consulate, we're extremely proud that our program with PointB MATTER is now recognized across Canada as an effective model for life science ventures to partner in the United States market. The C2MP program now boasts over 30 alumni companies, and we're proud to say that the linkages established during this mentoring period do not stop at the end of the program. As we welcome these 5 Canadian ventures into this year's cohort, we encourage you to connect with Matter's expert resources and leverage the Consulate's connections with the local ecosystem. This collaboration will play an even stronger role as our countries both look to build resilient economies in the post-pandemic world. Thank you very much, in particular to the mentors, for bringing your knowledge and dedication to the Canadian companies and to our C2MP program of the years. As we mark this, the 75th anniversary of our consulate here in Chicago, we extend our thanks to Matter and to this wonderful partnership that we have with you. Thank you once again, Steve. As I promised to be not to be long-winded. Sure enough, I've delivered. So thank you very much, and I hand it back over to you.
Thanks, Samir. That was short for a diplomat. What are you talking about? I wasn't sure I was going to do this, but I can't resist. I have to tell my Roy Norton story every year, which some of you have heard, the ones that haven't. So when we did the first program, Roy was the Consul General. And I'm not sure what's planned for tonight, but we used to have the refreshments first. And we had beer and wine and everything. And lo and behold, C2MP #1, Canadian sponsored. We ran out of beer. Roy assured me that never again at one of these would we run out of beer. So I'm assuming that won't happen tonight. So that's in honor of Roy. Okay, for those that may, how many here at C2MP for the first time? Mentors? Okay, 1, okay, that means the others are good. So I want to give the ground rules for everybody. So we have 5 great companies. We've had a lot of prep sessions the last few weeks. They work really hard. I must say, they're some of the most coachable teams we've seen. The way this program works, we're going to run a few minutes behind, but I'll keep us right on schedule. A few minutes behind the start. They are told they have to give their pitch, their formal pitch, with 5 slides in 5 minutes. And they're ready to do that. That does not include an opening slide and a closing slide. And I'm sitting here with a clock, and I told them I may give them a few extra seconds, but they're not going to get 5.5 minutes because that works, and it's hard to do. And if 4 of them do 5 minutes and 1 does 6, that's not fair. So they understand that, and I'm sure they'll all do it unless they get stage fright. Now, why do we do that? They're told, slide #1, tell us what problem you're solving. Slide #2, tell us what your solution is. Slide #3, tell us what's unique about your solution that the rest of the world doesn't know about. Slide #4, tell us whatever you think is important about your status, something relevant. Slide #5, tell us what your next steps are and what you want from the mentors. And then we go to the most important part, which is the 10-minute Q&A session. And I moderate, and I've done this a lot, and I tell the mentors, pay attention, stand up. If you have a question, which I hope you will, stand up, give your name. Some of you know how I do this. And give me a question. Don't give me a lecture. All right? And then I tell the mentees, give an answer. Don't give a lecture. Because our goal is to have in 10 minutes, 6, 7, 8 or more Q&A. And that's where you really learn about their ventures. What's the best, what they need, what their issues are. And then at the end, each one, are we signing up digitally? I didn't. Yeah. So is it in here with the link and everything, or it's gone? Oh, okay. After each presentation? Can we? Oh, okay. So make a note to yourself. All right. At the end, volunteer for ones that interest you. And if all 5 interest you, sign up for all 5 and prioritize them. We'll only put you on one, but we want a little flexibility, all right? So sign up for all 5 or 4 or 3, whatever. And we try and match your talents and your interests to what their needs are, okay? So that's the point of this. It tends to work pretty well. And I think we're ready to go. Anything I missed? Okay. Sam has really managed all this. She's terrific at it. So we're going to kick off with Careteam with Mina. And so I'm 7 minutes past 4:45, but I'm going to hold you at 5 minutes now.
Thank you, Dr. Gold. So my name is Mina Sandhu, and I'm the Chief Revenue Officer for Careteam Technologies. So there's a massive and growing gap between what is possible and what happens for patients with complex chronic conditions. We've all been in situations, whether you have a complex condition or not. How often have you gone through one physician and then had to repeat the information that you shared with another one? We've all had to do that. How often have you tried to help take care of an elderly parent or grandparent and you don't really know what the instructions were for them and they don't know their instructions? So you're having to dig in, maybe book additional appointments. The system is fragmented and disconnected. We need to close that gap and connect everybody, make sure everybody that's a part of the patient journey knows what they're doing. So Careteam is the most connected care plan platform available. With one solution, we connect every single individual, group, team, and organization along the patient journey. We are a cloud-based SaaS platform, and with Careteam, you can really connect, you can coordinate, and you can collaborate your way to patient success. So what is the benefit of Careteam, and what are we really doing? We're really making the right actions happen at the right time and making the right information available to everyone that needs it to participate in the care. That includes the patients, empowering them to take care of their own health, giving them dynamic, active, personalized action plans, involving their family, their caregivers, and every physician and clinician that's touching their patient journey. To date, we have been able to help organizations increase their capacity from 2x to even 6x. That's a significant leap in how many patients an individual clinician or group can see. We've had certain organizations be able to completely eliminate their wait lists. Some of our clinicians are able to change their prep time and reading and data input from 30 minutes down to 2 minutes. Huge savings of time. At the end of the day, we're really focused on the quadruple aim for healthcare. We want improved patient outcomes, improved patient experiences, improved clinical outcomes, and improved costs, so lower costs overall to the system. So for providers, they're seeing less network leakage, they're seeing lower total medical expenditures, and patients are seeing better outcomes and experiences. Clinicians are having more time back in their day to really focus on the care, and all the clinical teams involved in the care of the patient are now connected and understand what has happened to date, what still needs to happen, what do we need to do next. So with Careteam, we are quite unique in the fact that we are connected across ecosystems and multiple diseases combined. We are an overlay on top of existing software, so we're fully integrated with Epic and Cerner. Our information is both push and pull, and we can connect people on several different ecosystems, so several different organizations. One of our implementations has 39 organizations inputting into these care plans and accessing them. We can connect multiple diseases. Multi-comorbidities is really important. A lot of people that have diabetes may also have heart issues or kidney issues, and you need to be able to care for the patient, taking all of that into consideration. We have population health, individual and group population health built in. Predictive AI is an important element to our platform, and we want to be able to say, okay, we've seen if you miss 2 actions, the patient's likely to decline. We need to have an interjection at that point. We've seen this clinician's care plans are the most effective. Let's use those and adopt those across the organization. We really extend EHRs, portals, apps and devices. We're very integration strong. There's little to no code required at all with our workflows, and we customize each implementation with who we're implementing with. And to date, we have over 13,000 care plans, and we're at 47 different sites. We've raised $5.7 million to date. We have over $1 million in annual recurring revenue, and we're here to really make an entry into the US market. We need help with go-to-market, really understanding Medicaid, Medicare, value-based care, accountable care organizations, and really expanding our connections and getting as much coaching as we can. Thank you very much.
Nice job.
Thank you.
Right on time.
Thank you.
Okay, the floor is open for questions. So stand up, raise your hand, and ask questions.
Yes.
Yes.
Hi, thank you for your great presentation. Christine Rowan, question about the competitive landscape, what you see in Canada and what you expect to see in the US.
So with the competitive landscape, there are a number of different platforms out there. They're pretty similar between Canada and the US. And what I've went over in terms of our differentiators, none of the other platforms out there really connect across ecosystems. So if one group is on Epic, another one's on Cerner or Meditech, with Careteam, you can talk through all of those different platforms into one solution. So there are competitors out there. They lack in terms of the level of connectivity and the multi-comorbidity that we have. Does that answer your question? Or okay. Yes.
Hi, great presentation.
Thank you.
So who's your decision maker?
Who are you? Who are you?
I am Cynthia Ansari. Who's the decision maker? Who's your buyer?
So there's a number of different buyers. We focus primarily on providers.
So can I wanted to get into that, but in healthcare, I always distinguish, there's the decision maker and then who's going to pay for it. And they're not always the same.
Yes.
So,
Yes.
so go through those.
100%.
Okay?
100%. So we're targeting providers mainly, and oftentimes the decision makers and the buyers are chief medical officers, CMIOs. We would often have, chief digital officers or innovation officers that are looking to bring in tools and technologies, but they may not be the buyer, like you're saying. So they're heavily influencing the decision-making process, but not necessarily the buying. We also consult to more privatized clinics across the board. So there, the decision-making process is a little bit different. You go more direct to their chief operating officer or whoever's leading the clinics. And then we haven't delved into health plans yet, and it's one of the things we want to know, should we even sell into health plans? And that, I understand, is a very complicated buying and selling process.
So let me follow up and
Yeah.
push a little more. So you talked about some of the benefits in terms of better access, efficiency, all that stuff. There's a bottom line here somewhere.
Yep.
So how do you, when you're selling, how do you talk about that? It's going to cost them to buy this product. How are they going to say they're getting an ROI?
Yeah, what we're really trying to focus on is pulling the data out that shows capacity. So how many more patients can one clinician or a team see, and what direct impact can we have on medical expenses and expenditures? And some of that data, in all honesty, I still need to pull in terms of, we could easily do a calculation, and I could use the help here, is how much does each ER admission cost? Because we are reducing ER admission, so we can give an exact calculation of every ER admission we save will save you this much in terms of dollars spent.
You satisfied, Cynthia? Okay.
Thank you.
Okay, good. Yes, in the back? Yeah.
Yeah. Hi, Don Bora. Can you talk about your current revenue streams and then what you plan for your future revenue streams?
Yeah, sounds good. So currently we have implementations in health systems, programs, clinics as well, and we are going to continue selling to those types of organizations, but more so in the US as opposed to Canada. So majority of our sales have been in Canada, and we'd like to have more sales in the US and gain traction there, and start to incorporate value-based care and really understand Medicare and Medicaid and how we can sell with those programs.
And what
But the same implementation we've had in Canada would work the exact same way in the US.
the implementation? So is the pricing, or is this per member per month, per use per month? How are you building
So
the
we have
pricing?
set SaaS pricing. If you break it down, it really comes down to almost like saying $50 a care plan, but really our pricing is, most of our implementations are $100,000, $250,000, $500,000, or $1 million. Those are the larger implementations and what the pricing typically is. Up front, there's a small implementation fee, which will vary depending on how much customization we're doing as we do the implementation. We are really strong believers in having a thorough co-design process with any implementation we have.
My name's Kevin Donnelly. I'm a mentor, and great presentation. My question, you talked about predictive AI, and so my question is, where are you at in the regulatory strategy in the United States, and whether or not you need help from Matter?
Yeah, regulatory-wise, we have all of our necessary certifications, privacy, HIPAA compliance. So any implementation, any type of sharing of care plans is possible because we meet all of the current security and privacy requirements in the U.S.
So I was curious about FDA as well, whether or not from a regulatory standpoint, as far as a medical device and kind of the depth that
Because
your AI
it's a
gets into.
software, we wouldn't require the same FDA clearance. There's no device involved in Careteam. We are integrated with a number of devices that would have their own FDA clearance.
So how does that work? How do you integrate with the device?
So each device it's an open APIs often that we use to build an integration to a different device or platform, and it would vary device to device depending on how it works. But glucose monitors is a good example of one that's built into our care plan, so we can see where the patient's at and see where different actions, different steps need to be built into the care plan.
So I know we talked about this in one of the prep sessions. So you sign up a health system. They want to take this on. How does it actually work? Who embeds it? Do you do that? How are you compared to Xealth or some of the other?
Yeah, we do the implementation ourselves. It takes very little for us to actually do the implementation. Like I said, we go through a co-design system. So to give you a very quick walkthrough, a health system says system-wide, we're going to implement Careteam. We do configuration with them, with their tech teams. Shouldn't really be any coding required in that process. Once it's rolled out to all of their health teams, they have a single-click access. We're actually working on building a single-click out of Epic as well, so they don't even need to log into a different platform out of Epic. And that single-click brings you straight into Careteam. You see the patients, their family, their caregivers, other organizations, and their care plans. And you can go in as a clinician and create your own care plans. You can use templates. Perhaps the health system says, you know what, as a system, we're all going to use these templates. And they're dynamic, so they can be changed and personalized for the patient as well. And so that the patient goes in, sees their clinician says, hey, here's this platform that we're using. You can sign up at any point, pre or post-discharge. And then if they go to their primary care provider and they say, hey, we're on this platform, the primary care provider gets a single-click link access as well. So the whole network gets connected.
I also asked you, what do you do if a patient doesn't have a device?
Yes, which is definitely something that happens. So we have 100% clinical adoption, and it's about 75% patient adoption. So that 25% of patients that aren't using the platform, they get a printed version of the care plans. And hopefully over time, we get them the right resources and support to get them on board onto the technology as well.
So you have no liability. You're not dictating care. You're just taking the plan that somebody gives you, and you're in a sense a delivery platform
Exactly.
to get it to the patient.
Exactly.
Okay.
Yeah.
Great. Thanks.
Thank you.
Good job. All right, so that's how it works. So if you're interested, put a check next to it so you can sign up later on. Next is Fluid Biomed, Dr. John Wong. Now we're going to hear about a novel device.
Thanks very much, Dr. Gould. I have 5 minutes to teach you all about brain surgery. Otherwise, Steve's going to lobotomize me. So we are Fluid Biomed. We're developing the world's first polymer stent to cure brain aneurysms. We're an early stage preclinical VC-backed medical device startup based in Calgary, Canada. We're launching human clinical trials, and a $10 million Series A round. Again, my name's John Wong. I'm co-founder, CEO. I'm a neurosurgeon, academic and practicing, having trained in Canada at Yale. I received my MBA from Wharton. My co-founder, Dr. Ella Mitha, president CTO, also a neurosurgeon, but perhaps more importantly for the company, he's a biomedical engineer, having trained at Harvard. It's his technology that we're spitting out from the University of Calgary towards commercialization. So the unmet clinical and market need here is that of a brain aneurysm. A bubble on a blood vessel at the base of the brain that's prone to weakness, prone to bursting, can cause a stroke. Brain aneurysms are not rare. In fact, up to 1 in 20 people, President Biden had aneurysms, as well as Emilia Clarke from Game of Thrones. Younger and older people, 1/3 of people, unfortunately, with a burst aneurysm will pass away. Many patients need repeated procedures. With up to 5% of the population having a brain aneurysm, it's a huge TAM. The brain aneurysm device market exceeds over $1 billion already. And unlike, say, the more common or commoditized coronary stent or heart stent market, a neurostent, a neurovascular stent, each one retails for over $12,000 each, as opposed to $400 and $500 for a heart stent. This is a high margin product that really attracts the attention of the major medical device manufacturers. So what Fluid Biomed has done is create Resolved, a unique polymer-based stent. Let me show you this cartoon. So doctors like myself and my co-founder can now navigate tiny wires and tubes all the way inside of blood vessels of the body into the brain. And under X-ray guidance, we can then position these microcatheters and microwires across the orifice or the neck of an aneurysm, a bubble on a blood vessel. And we release a stent, a flow diverting stent, a high density mesh tube that then diverts blood flow to the normal blood vessels of the brain and slows down blood flow inside of an aneurysm, causing it to thrombose or clot off and then heal over time. Now, as opposed to the current metal stents that are permanent, ours is for the most part made out of polymer, so it will dissolve away, leaving very little footprint behind. Why is this important? So our polymer-based stent, as opposed to the, say, 6 metal stent competitors out there, this polymer is extremely soft and flexible. It allows for revolutionary versatility for physicians because now doctors can treat many types of aneurysms, not just a few types. And the polymer itself is very biocompatible. Very uniquely, it complements and is compatible with using other medical devices as well. Because the polymer is radiolucent or invisible on X-rays, this allows us to perform non-invasive follow-up testing. And so we can avoid those risky and painful angiograms that metal stents require. And because the polymer is bioabsorbable, it dissolves away over time, leaving, again, so that the patient does not require any future blood thinners. We have an efficient pathway of execution. We're at the end of the green with our VC-backed seed financing. We have engaged now with strategic partners, and we are about to launch our first in-human clinical trial. We know that the future clinical trials will require more resources, but it's important to know that startups like ourselves represent the lifeblood of innovation for the medical manufacturers, the major strategics. So the comparable acquisition exits have occurred between $150 to $380 million, all pre-FDA approval. This is our past financing traction. We raised a pre-seed round from local investors in Calgary. Our seed round was oversubscribed at $4.7 million and co-led by 2 US medtech VCs, Shanghai Capital in Palo Alto and Medis Innovative in Miami. We're launching a Series A round of $10 million, and the use of proceeds you can see there. But essentially, they revolve around the initiation of multi-center human clinical trials. So what's the ask? Well, for the Matter Health program and the mentors, we're looking for further guidance for value creation. In terms of engineering, we're a very tech-heavy company. We have 9 full-time employees. We have agreements with partners in manufacturing in US and Canada. Regulatory, we're already engaged with the ex-FDA personnel. Quality management, we have an internal QMS system. We're ISO 13485 certified. And at the university, we are clinical trial design actually experts already, and so we can execute. So we're looking for go-to-market strategy, value assessment, and reimbursement. Thank you very much.
John, very well done. He was teasing, but we talked in the prep. It's a complicated story if you don't know about aneurysms. I'm a vascular surgeon. I'm really intrigued and impressed with all this. Very, very well done. So we got 10 minutes. to ask questions. I got a bunch that I can ask, but let's get the audience involved first.
Your mic is on.
Sorry, it's on. I'm just not holding it enough closely. All right, who's going first? Yeah, Catherine.
Oh, sorry. Okay. Catherine Sastanoff, one of the mentors. Great presentation. Thank you. You mentioned that this dissolves over time. How much time? What happens after that?
The polymer itself is non-proprietary. In fact, it's used elsewhere in the body for different applications. And so the pathway through absorption is actually well understood because there have been other stents made out of a PLLA, that's what it is, poly-L-lactic acid. And the time frame for absorption is up to about 3 years. In fact, we have robust animal data. We have the stent implanted over 80 animals. Up to December was a 3-year anniversary for these rabbits that are hopping around with the stent. And so we're continuing to monitor them and take that data eventually to regulatory bodies like the FDA. Thank you.
So let me just follow up, because again, we talked about this. I want for the audience. So tell us a little more, without a lecture, about the pros and cons of permanent versus absorbable. You've talked about some of them, but one of the questions I always have, I forgot to ask on our prep calls, when things are absorbable, you get some inflammatory response. And how do you weigh the relative pros and cons of getting rid of it, which may eliminate your need for long-term anticoagulation, with some potential inflammatory response?
Yeah, thanks very much. Well, the special thing about our stent, it is made out of polymer that happens to be bioabsorbable. It's not the end goal here. And in fact, the reason why it's so beneficial is, again, the fact that it's extremely malleable and flexible. So we can shape our stent to the local anatomy, almost like personalizing the stent to that particular aneurysm or patient. The other thing is that because it's so malleable, we can use other devices in conjunction with the stent. So those two value propositions themselves are very important to the doctor at the time of the procedure, because surgeons are kind of like selfish people, like what's in it for me at this point? What's in it for me to help the patient at that juncture? With respect to the bioabsorbability, yes, it is bioabsorbable. And you know, our thinking here is that there's never been a demonstration of an aneurysm recurring after it has completely healed. So if your aneurysm is healed by one of these stents, you probably don't need the stent anymore. And if the stent does disappear, then you don't need to be on those lifelong blood thinners as well. So those are the major value propositions that we see.
Yeah, so I asked him to make sure he did a nice job. What does heal mean? So it fills with clot, and presumably the opening, the orifice, is occluded, and it makes sense. I'm not sure we totally know, but it makes sense that it can just sit there forever without trouble, right?
Yes.
Okay. Other questions?
Zo Kwan, one of the mentors. Great presentation, very exciting technology. What's your intellectual property?
Yeah, thank you. So we came up with this idea in probably 2014 or so, and that's a different story in itself, but we've been working on this project for a while as academics with PhDs and postdocs. And along the way, as we came to realize that this project really has legs and really can go further than just being a science project, so to speak, that's when we embarked on the commercialization journey. To answer your question, the IP, so the IP is wholly owned by the company. We have a broad-based patent in Canada. Wilson Sonsini is our legal partner for IP in the California area. They're working with us.
She's asking, what is it?
Oh, what is it? Yeah. So we have patents approved in Canada, patent pending internationally, including the US, patent for a stent delivery system issued in Canada, and more importantly, with respect to the relationship to the university, I'm a university professor, but the university is our partner, 5% equity, dilutable after the first million, no pre-existing licensing or royalty obligation.
John, the stent delivery system, you mean the device to put it in there? It's not the stent itself?
No, the stent itself is that mesh tube that you saw,
yeah.
But there are certain nuances with a polymer stent that are very unique, so to speak, and we've developed a proprietary stent delivery system that's married to that technology.
So are you, if I'm tracking, so someone else can make this stent, same stent, there's no patent on the stent.
No, there is a patent. Sorry, there is a patent on the stent, and there's also other patents that we have pending related to it. Thank you.
Okay. All right.
Yeah. Thank you.
Over here, I can't see. Oh, that was your question. Okay. All right. Let's get someone new. Catherine will come back.
Hi, Matt Oy. Can you tell me a little bit more about the engineering and manufacturing of this the product? I assume there's a stent, and then you said there's a device. What are some of the challenges? Because it's probably need to be very small, and somebody really needs to be able to be expert to put it in the brain.
Yeah. Well, I will say this,
John. I'm not being funny here. Concise answer. All right. We got discussion later on if you really want details. So give them a high level answer on that. Okay.
Very complicated in terms of manufacturing. The design is actually quite elegant. In terms of the deployment or positioning and release of the stent, as an end user, we know that we have to make this very simple for the surgeons involved. And so it very much follows the existing stents. They don't have to relearn new techniques at all. Again, because we know that if we can't do that, then we will not get market adoption. So my co-founder has probably placed a stent 100 times into animals at this point, and we do have a line of sight to first in human, likely in Europe, in the very near future. Thank you.
Steve Garko. John, can you just elaborate? Value assessment committee. What are you what kind of questions are you looking to get answered by that?
Yeah, thank you, Steve. We're obviously experts in medical devices in terms of the design, development, and such. But one of the things that we should gain further insight into is how do you bring it into the hospital itself. And in the US, there are typically value assessment committees, and what we're looking for is advice in how do you approach a body like that, what kind of documentation is necessary, pricing, reimbursement, things like that. That would be very helpful to help us flesh out the story for our device.
Are you going to be priced comparably to other devices, or more or less?
Yeah, this is a very interesting market. None of these neurovascular stents are reducing in price. They're only increasing in price. And the strategics are basing that on more and more features. So we look at our stent as having lots of unique features. And so does that mean that we price higher? Likely, but that's a different conversation down the road.
I want to follow up a little variation on what he asked, which is, and I want to come back to regulatory, but let's say you got approved, okay? It's not the value, not the dollar. To me, as a clinician, it's physician behavior. You touched on this. So FDA says it's safe. It's probably a 510K, right?
PMA.
This is PMA. Okay,
PMA.
We'll come back to that. All right, but you get through your FDA, okay? That means they've said it's safe and effective. Your value committee says, I think I can justify the price. What's going to convince the physicians? Will they all buy into the fact that absorbable is better, or are you going to need data?
Yeah, I think all of the above, in that the unique aspect of our community as a relatively small number of specialists is the devices that we use are chosen by the physician. So it's very rarely that an administrator will enforce that you have to use, say, the cheapest stent or what have you.
I'm saying it's in the hospital, more or less expensive, I don't care, it's there. What will persuade the physicians to use this as opposed to what they've been using and know their results with?
Yeah. So with our product, the unique capabilities of our stent in that now we can use this particular stent to address many types of aneurysms. There's a certain amount of flexibility and versatility with our stent as well. In fact, when we've disclosed some of our concepts and prototypes to key opinion leaders at various medical conferences, they are equally as excited as we are, because this is our baby, so to speak. Everyone thinks our baby is the most beautiful baby in the world. So we need feedback from other KOLs, and so far the feedback has been incredible.
Okay, I'm taking the last question. So PMA, if you don't know, for a device, it's a pre-market approval. It's kind of like a pivotal drug trial. It's a randomized prospective design trial. What's the endpoint? What do you have to show? You have to compare this to standard of care? Or
uncertain.
Uncertain.
Uncertain, partly because it depends on our indication. So if our indication is an orphan type of aneurysm, then we will not need a double arm.
So I challenge you. I think you need help on clinical trial design and regulatory.
Steve, we're running a 1,000 patient neuroprotection study right now. And I'm not bragging, but the University of Calgary is a phenomenal team of.
I'm not saying you don't know how to do clinical trials, but have you spoken to FDA yet?
We have spoken to the ex-FDA person, been there for two decades, so there are
But he's ex. Okay. Anyway, lots to talk about later
lots
on.
of talk. Oh,
good.
By the way, I'm
job.
coachable. I'm coachable. I don't want to push back. I'm coachable.
He's very coachable.
Thanks, Sarah.
Hi, folks. Ashwin Cuddy. I'm one of the principals of HealthEMe. I'm going to avoid the clicker because that intimidates me, so I'll stick with the laptop. So HealthEMe looks at a problem specifically around mental health. So one of the things that we have seen in mental health is, especially during the pandemic, we have seen sort of a growth or an increase of demand for mental health care services, while the supply has been exactly the same. So the bottleneck that we are seeing right now is that there is only so many care providers to the patients that we have or the potential patients that we have. And some of the solutions that have come up are around telepsychiatry that are provided from either governmental institutions or from healthcare institutions. And what that does is it replicates the same issue, which is there is only so many care provider hours that are there to serve the patient. And so what we are looking at is whether there is a solution that we can bring to bear to the market. So in Canada, for example, we have a 6 months to a 1 year wait list for a patient to see a healthcare provider, specifically in mental health. And so what we said was that why don't we build a solution that takes clinical tools that are evidence-based, and this is based on Dr. Stan Kuchar's work, who's now one of our senators. And what we have done is we've consumerized all those tools. So from assessment tools to journaling tools, resources, care plans and what have you, medication management, we have put it into a consumer application. And what we say is that instead of going through generic group therapy sessions or generic resources or, God forbid, Dr. Google, you basically get a soft prescription from your healthcare institution for downloading the application. And where it helps you is in 3 stages of your care journey. 1, sort of pre-care. So before you actually get clinical care, you're supported by the application. 2nd, once you get into the clinic, you can actually integrate it fully with the FHIR or HL7 compliant EHR, EMR. And last, if you decide to transition away from your current care provider to another, you can certainly do that. You can take your data with you as well. Some of the bonuses of sort of going with sort of our route is that it sort of goes away from what we have sort of traditionally seen, like the Calm apps of the world, which is around wellness. And I don't knock it. They've raised a hell of a lot of money and they're valued quite heavily and quite highly. So I don't knock that. But where our value proposition comes into play is that we are actually fully evidence-based, fully research-driven. Our clinical tools are actually being used in about 30 to 40 countries. And all of the IP is owned by us. And some of the other things that come up as well is that we've already been approached by 4 different industries: healthcare, insurance, pharma, and academia, in post-secondary especially. And then, of course, different illness profiles as well. So it's not just mental health. It can actually be repurposed for chronic illnesses like cancer care, diabetes, dementia, heart and stroke, and what have you as well. What are our milestones? We're currently in our initial seed funding stage, so we are raising money at this time. So far, we have bootstrapped the entire entity, and we have used sort of internal resources and monies for it. We already have leads in our sales funnel, both for Canadian and US commercialization. We have 3 clients in the central Canada that we are currently working with to close. We have on the East Coast a commercialization pathway to the Nova Scotia Health Authority, which is our East Coast Health Authority, as well as a First Nations and Indigenous trial that's also being run in partnership with the Government of Canada on the East Coast that will potentially go all across the country. And then we've got a unique opportunity that I just talked about earlier before this presentation, which is around sort of a community care model that has just recently come up. So one of our larger grocers, and who also owns one of the larger pharmaceutical distributors in Canada, Sobeys, they have come up with a unique proposition for giving rural health care in the East Coast and across the country. So what they do is they put in LPN or an RN in the community care clinic, and they provide them with a suite of technical solutions. Our solution actually integrates fully with that back-end EHR and is fully compliant, and we already are in negotiations with them to take it all across the country through all their community care clinics in a box, so to say. What are we looking for in terms of support? There are a few things that's on the table. One of the things that we're looking for, of course, is right now the three sort of key players in the enterprises: myself, my business partner Fadnil Shazli, and our clinical ambassador Dr. Alex Abagnale, who is the chief of psychiatry and the head of psychiatry at Dalhousie University. And so between the three of us, we've got a lot of mental health, administrative and clinical experience. Between my business partner and myself, we've got about 2 decades of that. And then the clinical ambassador, of course. But what does that advisory team look like? What does that advisory board look like? We're raising money. We'd love to know what we're doing right or wrong with our term sheets. We have a SaaS pricing strategy that we have come up with as well that we'd like to get some advice on. And then, of course, what the sales strategy should look like coming into the United States market as well. Because we have 4 different industries, we have to look at what that looks like and whether there are the uniquenesses that we need to sort of account for as we come into the United States market. With that, I'll take your questions. You whipped us in shape is basically 2 sessions of this, honestly, before that, yeah.
I frightened them. Were you the one, were you 6.5 minutes? Some were 6.5, yeah.
That's me, yes.
6.5
Sam says yes, no, I volunteer. I was one of them.
And you slowed down.
I slowed down, I know, surprising for me.
See, we got the fun of working with them for a few weeks. Anyway, the floor is open.
Hi, Pete Maslowski, I'm one of the mentors. You talked about 4 different customer segments, so I'm just a little confused about who really is your customer, and then what is your value proposition to them? Like, what value are you bringing to them?
Great question. I'll try to keep it short before Steve comes at me again. So we started out with healthcare institutions as our customer. And so what we said was, instead of going to a B2C model, we would do a B2B sort of sales pitch, and then it would be a B2B2C sort of mechanism where we would get to the consumer. So we started with healthcare, and then we started getting questions from post-secondary who were also seeing sort of an increase in demand for their counseling services, and they have infrastructure limitations, so they don't want to increase their sort of overheads, and so they were looking at supports. And then we had insurance and pharma come to us from the US and Mexico when we were here last year, and in Mexico as well. And so they're looking at it from a CSR standpoint of kind of distributing it to their insured and their prescribers, primarily to get the aggregate data. So our customers are basically the institutions. And the value proposition to, let's say, the healthcare institutions is very simple, which is when we have patients that are in a wait list for 6 months to a year, they continue to deteriorate. Keeping them in the community is far better in mental health situations or mental illnesses, rather than seeing them in the inpatient side of the house. And one of the things that we have seen sort of, at least in Canada is, and Australia and New Zealand that we have also had conversations with, is that the inpatient side can no longer take any more patients. They just don't have capacity to take on all the demand that's coming through from their front doors. And so they want to keep people in the community as much as possible. So we've had sort of step levels of care that they're trying to push people out from. So what we say is that at $10 a user per month, let's say, as a SaaS pricing model, that far outweighs the cost of an inpatient day cost that an institution would go through, which would be anywhere from $2,000 to $5,000 a day.
Is that a good answer, Pete?
I have lots of follow-ups.
So Pete's an expert in digital health.
Absolutely,
right?
we can talk after if you like, yeah.
I can't see.
Please.
Yep.
Excuse me, Don Bora, mentor again. Same question for you. Where's your revenue stream right now, and what revenue opportunities, maybe that's a better way to phrase it, revenue opportunities do you see in the future?
So we are sort of pre-revenue at this stage. We have our sales leads that we have are basically conversations that we've had that have not led to sort of closing those deals because we've just been slow out of the gate. We've just literally incorporated early this year. We have gone through clinical trials in central Canada, and we have sort of all of that done through Queen's University and Kingston Family Health and Hotel Dieu. So revenue, as far as that's concerned, we have one sort of confirmed stream coming up from the East Coast with a healthcare institution there. We have another one with the trials that I mentioned with the First Nations and Indigenous populations with the government. So those are currently on the books. That's going to be implemented Q2 and Q3 of this year. And then we have, as I said, 3 institutions in Canada that have already showed interest. The only sort of lagging sort of feature with that is that they have Meditech, and they have a very old version of Meditech that we have to integrate with, but we are sort of integrated with all the other ones. And that's where sort of our revenue will come in. The raise that we're going through right now is literally to accelerate all these sales leads that we have in our funnel. Yes?
Thank you so much. Fiona McEntee, I'm also a mentor here. The bottleneck that you discussed, that exists in Canada. So I'm from Ireland and our healthcare system is similar enough to Canada. So I totally understand that bottleneck. But do you know that the same bottleneck exists in the US in terms of like those providers? Is that similar in the landscape here?
It may not necessarily be at the bottleneck that's the issue, but I think our value proposition speaks for itself. And I think, looking at, so we were in Georgia last year, not to get into a story mode and get smacked around by Steve again, but we were in Georgia last year. So Georgia Tech, for example, one of the things that they did was because they saw such a huge increase in counseling service questions, they started to partner with the JED Foundation in New York that we know very well. We know the organization, and what they provide is basically a 1-800 number. And so they give all their students the 1-800 number to go and basically get very quick counseling services, and then push them along to their family physician in primary care. So what we have said is that we can actually provide that service to them as sort of a precursor to actually going to getting counseling services or into primary care or secondary care if they need to as well.
So that's a good question. See, I don't know if I'm right, but I'm going to tell you what I think, which is that this is a worldwide problem, and COVID may have made it worse, but I think COVID really unroofed the problem because people were more willing to talk about the fact that all these behavioral health issues exist. Right?
If I can just follow up on that, that's a great point. Thank you. So in Canada, in Australia, and New Zealand as well, COVID, the solution that came up from the governments during COVID was they invested somewhere along the lines of $40 to $50 million each into solutions in Canada what they call Wellness Together Canada. So I was on the expert review panel for the minister for that platform that they built in Canada with 5 other psychiatrists, one of which actually is from Harvard, and then we had a consumer advocate as well. And when we looked through that, what they did was they literally took 5 or 6 different digital health solutions, cobbled it together and said, okay, Canadians, because you can't access your mental health provider, try whatever you can from all these different 5 or 6 applications that we have basically purchased for you, and then we are giving it to you now. So one of the things that they're looking at is what's V2 of that look like, so version 2 of that look like. And what we've talked about is consumer applications like ours that could very nicely and neatly fit into that. So I think it's not just a Canadian problem, honestly. Like you said, Ireland and other countries as well are sort of experiencing that. We were in Korea and they have similar, if not worse, problems as well, because there is a huge stigma associated with it as well. There was another question there.
Hi.
Hi.
Nice presentation,
Thank
Jed
you.
Weiner, another mentor. Many of us are familiar with the challenges of mental health in rural communities.
Yes.
And I'm struck by the patient population in your clinical trials, including Indigenous people and First Nations.
Yes.
Do you anticipate being able to do well by doing good? Is that part of your mindset of how you tell your story?
It would be fantastic. It's just one of those things where we say feed the pocket and feed the soul. So I think that it would be fantastic to have that kind of conversation. I think one of the things that has come up from our First Nations and Indigenous conversations is that we don't know the population as well as we should. So what we've done is we actually have a strategic partner for that, Ulnaweg, who is actually a incubator for First Nations businesses, but also has an entire knowledge and help sort of platform that they actually support First Nations and Indigenous communities with. Is they're looking to see whether they can contextualize what we have. So they want to take Western medicine and they want to add their own sort of contextualized what they call clinical care models and therapies into the application as well. And ours is fully white labeled and customizable because we have a content management platform, so we can incorporate that. I think it'll be fantastic. I think one of the things that they've actually opened our eyes to is they don't just have exposure in Canada, but they also have exposures into New Zealand with the Maori population there. So even taking it further into other First Nations and Indigenous populations would be absolutely brilliant because they have been so disenfranchised as far as sort of access to care is concerned. Thank you for the question.
Hi, Bill Manganero. You mentioned Calm, but it seems to me that you're positioned more against some of the, I'll call them commercial digital platforms. It's a relatively crowded space. Who do you see as your competitors, and how do you intend to position against some of the Teledocs and so forth?
It's a fair question, and one of the things that we've said is that Calm and applications like that are very wellness driven, and so they're very much looking to go direct to consumer. They have spent a lot of money just marketing to the consumers, and they've tried to get their application direct to consumer as opposed to kind of going through the care models or the clinical care models. We want to be entrenched fully into the care model. And so ours is fully, so if you look at all our assessments and everything that's there and all the resources that are there, there is years of research, decades of research that are associated with it that we can provide in terms of papers that have been written and sort of, trials that have been run. So our sort of competitive space right now, yes, there are tools for mental health services, but what we say is that our tool basically allows for an individual to be supported where there is no care, there is no support currently. What people provide is for patient applications that they can take away. They provide for telehealth or telepsychiatry. They provide for wellness applications, but no one actually takes care of, not necessarily replicating care, but sort of supporting them while they don't have care at that point in time. And then what is that bridge for individuals who are going from, care provider to care provider, or while they're having, sort of breaks from appointment to appointment, who takes care of them, and how do they do that legitimately? And that's where sort of our application fits in, which there is neatly no real competitor, but of course we have to consider all these other ones that are out there. And applications like Calm have done very well for themselves with raising a ton of money and sort of creating a valuation and value proposition for themselves. So we don't discount them. What we say is that I think there is more to ours that has clinical validation, therefore hopefully better health outcomes than a wellness application would have. Thank you. Thank you.
All right, thank you. We're doing great.
Thank you, everybody.
Nice job. All right, next up
Thank you.
is Mikata Health, and Megan is going to give us our talk.
I'm Megan Nolan, and I'm here with my partner Kyle Nishiyama, and we're the co-founders of Mikata, where our mission is to make it really easy for clinics to provide outstanding care to every one of their patients. Our software is trusted by hundreds of clinics across Canada, and we're really excited to be here today with you to work on bringing it to the United States. Kyle is a data scientist, and I'm a user experience designer. And so when we started the company, we spoke to a lot of patients, doctors, really anyone who worked at a clinic. We'd sit with them at their desks. We would sit in the waiting rooms and really try to understand what gets in the way of outstanding care. And what we saw firsthand is that they're spending very little time on patient care at all. Their days are consumed and filled with tedious tasks, things like scheduling, phone calls, paperwork, and a lot of charting. In fact, for the average primary care doctor, they now spend more than half of their workday charting. And then they go home and they spend another 1 to 2 hours a day charting just to get it all done. Obviously, this takes away from the time they have with patients, but it's also widely recognized as the #1 driver of provider burnout. This is a huge problem for both Canada and the United States. It means people are exiting the profession at unprecedented rates, and it means it's harder to bring people into the profession. And these shortages obviously impact you and I as patients because it makes it very hard for clinics and health systems to provide the kind of access to care that patients need. And that's really where we come in. So at Mikata, we've developed an EHR-integrated automation platform for ambulatory care clinics, and we tackle some of the most time-consuming workflows before, during, and after an appointment. So we reach out to patients with automated SMS and email messages. It's very easy for them to interact with, and we help them with things like scheduling, confirmations, prep instructions, information collection, and save the clinic teams hundreds of hours on phone calls and paperwork. During the appointment itself, we dramatically reduce charting by listening to the patient-provider conversation and using natural language processing to automatically generate that chart note in real time. And finally, we enable clinics to reach out to patients with personalized follow-up and re-engagement messages, things that improve patient satisfaction and, more importantly, their actual health outcomes. We work with some of the biggest primary care, specialty medicine, and diagnostic imaging providers across Canada. And they love Mikata, #1, because of the very high patient engagement they see with our platform, more than double other solutions. The reason that we're able to achieve these industry-leading results is because we focused on creating a very simple and delightful experience for patients. No apps to download, no logins to manage. Secondly, we look very holistically at the clinic's operations, and we help out with workflows for the staff as well as the providers. And in this way, we can connect things that others can't and really provide automations and benefits that just aren't provided by some of the other more narrowly focused tools out there. And then finally, we offer a very high level of customization and support for our customers. So this obviously makes them very happy with us, but it also means that our platform gets deeply embedded into their day-to-day. We're a rapidly growing B2B SaaS company. We're powered by a small but very mighty team, and we're integrated with Canada's largest EMR providers, covering 80% of that market. and we're ready to integrate with US EMR providers as well, or EHRs. We have over 900 providers actively paying for and using the platform, and we interact with over 500,000 Canadians each and every month as part of their care. We've exceeded $1 million in annually recurring revenue, and we're really looking to accelerate that growth further. And that's why we're here. We're looking to expand into the United States, and we'd like to get our first customers up and running on the platform by the program's end. And to do that, we're looking to build a team with expertise in sales strategy, so people who can help us build our go-to-market plan, who can help us how to understand how to have conversations with decision makers at clinics and health systems to get our software implemented. We would love to work with some operational insiders, as we're calling them, so people who understand the workflows and the pain points that clinics and health systems face. People who've maybe had experience implementing these kinds of software tools would be really valuable. Really love your insight on how we need to adjust our product to meet the needs of the US market. And then finally, we'd be looking for anyone with connections to potential customers, so primary care, specialty, diagnostic imaging for us, or even potential partners, so EHR vendors that we can integrate with. We're really excited to make outstanding care easy here in the US, and we hope you join us. And with that, Kyle and I would love to take your questions. Thank you.
Again, nicely done, nicely done. I got to tell you, these are the best teams we've had ever. So congratulations to all of you.
Thank you.
Very nicely done. See, I heard this. This is just like having Alexa when I'm in the examining room. I sort of stopped doing clinical medicine before the EMRs, so I never had to deal with those screens and stuff. Or they were coming and I ignored them. And I don't like it when I go to physicians today and they're embedded in their screens, right, and not making eye contact and talking to me. I know they need to do it. So I think this is fantastic. So, questions?
What actually is your revenue stream model?
Yeah, absolutely. So currently we sell directly, so the clinic would be our customer, and they purchase the software at a monthly SaaS subscription that's usually based on kind of like per provider. So if they have 5 providers, they might buy 5 licenses from us, and they can kind of customize the package depending on what kinds of workflows they're interested in automating, and kind of go from there. But yeah, it's a monthly subscription model.
But let's tease out what you mean by clinic. So here, right? So if we go to Northwestern, University of Chicago, University of Illinois, there's a big, are you selling to the health system? Or when you say clinic, what do you mean by clinic?
Yeah, that's a great question. And I think one of the things that we're really looking for help with as we come from Canada to the United States. So many of our customers are individually owned and operated clinics, or they have a few locations. Okay. And we do have some that are quite large, but not at necessarily like a health system level.
Okay, all right.
Yeah.
So part of it is understanding the system here in the United States.
Absolutely,
okay.
Yes.
All right, well, we got some experts in the audience. Okay, yeah, I see another hand, yeah.
Hi, Don Bora again. I can see your TAM. It's very clear, and I see your TAM in your presentation, but what's your SOM? Like, what's the market you're going after right now? Because what I'm seeing is it's very generalized to any potential patient audience. And I'm just wondering how you're handling the demographic shift between old and young.
Yeah, do you want to take that one?
Sure, yeah, so we're currently targeting clinics that were integrated in their EMRs across Canada. So that is the family practices, the specialty medicine, diagnostic imaging. Likely one of our kind of niche entry points in that SOM for the US is the diagnostic imaging as well as for a main target.
I don't understand the imaging. I thought this was sort of to assist the doctor.
So a lot of the front end pieces.
You never see the radiologist when you're getting imaged. You see a tech.
Yeah, so a lot of the front end and follow up pieces, less so on that the scribe in the visit.
Okay.
Yeah.
Okay. Yes.
Yeah, Matt Boy, who do you see as your competitors? Number one. Thank you. Number two, do you expect this to be something like a change in method for physician, or is this something that is they're already used to it with another piece of software?
Great question. So I think some of the biggest competitors here in the United States, one on the operational and kind of upfront patient engagement tools would be Luma Health. So that would be an example of kind of more along that appointment management piece. And then when it comes to the charting piece, kind of during the appointment, some big ones would be DeepScribe would be one of the more well-known competitors here. I think what sets us apart is that we have taken this really comprehensive approach, because both of those examples, they're focused on just one piece of the puzzle. And so by connecting the workflows, we're actually able to tackle some tasks and workflows and provide some benefits that you can't unless you actually have all of the pieces in place across before, during, and after. If that makes sense. And the second question.
Do you think that this would be a change in culture for
Yeah.
He's asking, will this change in culture for workflow?
Hopefully a very positive change in workflow and culture, because right now they're like married to that keyboard. We can definitely chat more about this, but I will say there's a couple different what I would call charting personas. We kind of call them type 1 and type 2 charters. And so I think we're going to start with what we call type 2, and that's a physician who does most of their charting after the visit. And there I think this can really kind of seamlessly integrate with very little change to their workflow, except that they spend way less time after the visit charting. But yes, I would love to chat more about that.
Yeah, but let's talk again. I know we did on one of our calls about, so all these things cost money, right? So to use this, somebody's got to pay you money.
Yes.
How are they going to get a return on that investment?
Absolutely. Do you want to take that one?
Sure. Yeah. So they're seeing big returns on the staff side. So in terms of the staff hours, saving time, making the phone calls, communicating with the patients. So
I love that answer, because I always say the same thing. Everybody tells me I'm going to save these hours. I always answer, I don't think that means much, with two exceptions. One is you save enough to get rid of somebody, right? So you get rid of an FTE. Or two is you have a backlog and you can get more patients in. So what's the answer here? Saving.
Yeah, so they're seeing more patients, and I think particularly right now with the shortages in getting staff in, that they don't even have that option to kind of hire and fill those gaps and take care of those tasks.
So you get more throughput, you're saying.
More throughput. And then the other big difference, we see no-show rates drop by 50 to 80%. So that's a big revenue value for them. Because
why would this drop no-show rates?
It's the engagement with the patients and having the patients have the right information, knowing about their appointments, coming in more frequently.
Okay.
And then obviously kind of for the physicians, seeing that more patients and getting that time back as well.
Okay.
Steve Gargo again. Maybe I don't really understand the patient part of what you're doing, because what you showed was a satisfaction survey.
Mm-hmm.
And to me, I was thinking that there'd be a lot more that you could integrate with the patient. Maybe you've done that and you just haven't shown that. I mean, for instance, making sure that patients take their meds, making sure that patients are stimulated to do a particular thing.
Mm-hmm.
Is that what you do on the patient side too, and we just didn't see it, or is that not part of your vision?
Yeah, so I think for sure this is just like a quick tease. So hopefully you'll ask us lots more questions like this so we can talk your ear off about it. But basically the platform enables patients to, in a very self-service way, to book their appointment. They receive notifications about their appointment. They can also engage in prep instructions or information collection. So if there's say you're coming in for a mental health appointment and the doctor would like you to complete a PHQ-9 standardized questionnaire beforehand, we can assist with that. And then when you're in the visit with the doctor, that's where the scribe and the automated charting comes in, and then afterwards we can follow up with you as well to ask you how your visit was, or how are you doing now that you've seen the doctor for this issue.
So it doesn't deal with the patients at home. They've been told to do certain things, and there's no way in your system to kind of either tickle them to make sure they remember to do things, or to report back that they are, or anything like that?
You could, because the platform is very customizable in terms of what touch points you want to have with the patient. So if you want to send them something a week after, 2 weeks after, 1 month after, you certainly could. And again, you could attach certain instructions.
It's not real-time monitoring.
It's not real-time monitoring. No, it's more kind of set up beforehand, automated. Yeah. Yes. Sorry.
Often, I'm sorry, Steve. If I'm belaboring, just tell me to shut up.
No.
To me, if a lot of the burnout is from nurses having to call the patients to say, "Did you do this yet? Did you do that yet? You know, what have you done on this?" And so what I was thinking is that if there's some sort of way for your system to ping out to the patient, have you done that? You eliminate that from the nurse having to do that.
Yeah.
And I just didn't know if that was integrated into your system.
Yeah, so I think probably currently it's maybe more basic or more kind of like set up beforehand. It's not too like dynamic there with the patient, but certainly something that is like there's potential within the platform to support it. Yeah.
Customizable.
It's very customizable, yes.
Great. Very good. All right. Thanks everyone for the questions. So remember, I hope you're putting a check mark or making a note of which ones, and you're all going to sign up for all of them so we can assign you. Now we have a treat because Cerebra, the last team, their flight was canceled. So we're going to do this with the wonders of technology.
My name is Patrick Crampton, President and CEO of Cerebra Health, and we're here to put the sleep back into sleep medicine. Next slide. So why is that? And the problem is that sleep diagnostics is broken. The gold standard for sleep diagnostics, polysomnography, is locked behind the walls of a sleep lab. It's costly, inconvenient, poor patient experience, and depending on where you are, long wait times. The response has been a move to home sleep testing, but those tests are just geared to screen for sleep apnea only. They don't even measure sleep and miss out on the other 30 major sleep disorders. In the end, valuable information is lost, whether it's missing sleep entirely, or even when we do record sleep information in the lab, we use a methodology developed in the 1960s that just loses so much information that's in the sleep signal. The result, CPAP is a great example. Adherence has been stuck at 50% for the last 10 years. Poor outcomes, wasted healthcare dollars, and lost profits for many industry players. Next slide. How does Cerebra solve the problem? Well, there's two ways. The first way is our technology moved the sleep lab to the home. So it's the first patient-applied polysomnography in the home, same standard of technologies you get in the lab, and high quality success. Patient success is phenomenal. We have piles of experience up in Canada, and it's built for telehealth. Remote data upload, ability to interact with the patient in their home, really set up for moving towards patient-centric care. But the more exciting thing on the next slide is what we do with the information we get. And that's where Cerebra's proprietary technology comes in. Our patented ORP sleep depth metric microanalyzes the EEG signal and pulls out a lot more information that changes how we look at patients, look at sleep, and diagnose and guide therapy. It's the only PSG metric that has actually been proven to reflect how a patient thinks they sleep, how they feel the next day. There's research that shows it predicts when someone will feel better with CPAP. And of course, when therapy makes you feel better, that's when you tend to stick with it. And there's even more recent studies showing its predictive nature in terms of predicting longer-term CPAP adherence, which is the ultimate goal. If you'll indulge me just for a second, the charts, the gold charts, are the way we look at sleep today that many of us would be familiar with, stage 1, 2, 3. Two subjects that through any physician would say largely look like a normal sleep pattern. However, through the lens of the ORP metric, look dramatically different in the blue charts. The patient on the left has what we would consider a normal sleep profile. The patient on the right, dramatically different, being held back from shifting to the left to the deeper periods of sleep, and a classic CPAP responder. Just to give you an example. Next slide. So where's Cerebra at? We're really in a stage of building for US launch. A couple key milestones in place. We do have FDA authorization as a Class 2 medical device. And within the field of sleep disorder diagnostics, there is an existing G code for this technology. So G, for those of you who aren't familiar, is a temporary code. Not all payers cover it, but there's a lot of opportunity in the market today. But we'll talk about that in the next slide. Our business model: we sell devices to sleep labs, hospital sleep labs, independent diagnostic testing facilities. The hardware goes for $12,000 a device, and then there's a software subscription that follows for the scoring technology that runs, depending on volume, around $10 a study. Couple key proof points: we've secured a provincial payer contract with the province of Manitoba. 2-year contract, 10,000 studies, $6 million in revenue. Provides a really strong base for the financials for the company, but more importantly, a proof point for the technology with a major payer. And then secondly, from a US market distribution perspective, we signed a deal with the #1 SaaS provider for workflow management for sleep labs in the US with 1,500 locations that manages over 1 million studies a year. So really excited about that. But where we need your help and where we'd love to leverage this opportunity is in 2 main ways. One is the current technology, moving the sleep lab to the home and understanding, the implications of the G code and where things are going in terms of converting that to a CPT code. So navigation of the current, coding environment, reimbursement, and then longer term, this amazing technology around ORP. How do we monetize and reimburse that in the longer term and get the true value from the technology? What evidence do we need to build to get payers to recognize the value that it can have in terms of changing the standard of care? Ideal mentors, obviously payers. VA Hospital Administration is the teaching hospital in sleep. Over half of sleep doctors do their fellowship in the VA. Obviously clinical sleep physicians and market access specialists. So yeah, so that's Cerebra in a nutshell, and look forward to your questions.
Great, Patrick. Nicely done, and thanks for doing it over Zoom. So we're going to take questions. I don't know. I guess you won't be able to actually see people.
Yeah.
I'll ask them if you can hear. We ask everyone to stand and give their name, and then ask your question. We'll try and make this work. Okay.
Excellent
Yep,
presentation. My name's Kathy Tonner. I'm a nurse, and I think you have a great idea. However, I had a question about your business model and how you plan to scale it, because you did say the unit costs $12,000, the device.
Did you hear the question, Patrick?
Just bits and pieces about scaling $12,000 a device.
Yeah, she loves what you're doing. She's questioning the business model at 12 grand a device. How do you intend to scale that?
So it's from a competitive market standpoint. For a device like this, the life cycle's going to be 4 to 5 years for it. There are other competitors in the market moving the Type 2 lab in the home, and so the market price is kind of established out there. So from all of our intelligence, that's sort of where the market is in terms of these studies. The in-lab devices are far more expensive, and then obviously correspondingly the level 3 studies are relatively cheaper. So it's we have a number of clinical demos out in the field, and the pricing certainly seems to be in the right area so far.
Well, I think you should start with the VAs. I think that was the good spot to start with, the VA hospitals. That's my suggestion.
Are you connected to them?
I used to work at the VA hospital. I was a nurse there. Thanks.
Great. I want to ask a question for myself to clarify. I'm not sure I thought of this when we were prepping.
Yep.
You talk about 2 benefits in your talk today. One is doing this at home versus in the sleep lab. And I don't know how anybody can sleep in the sleep lab. I mean, that just seems to be, you're set up to get a bad result, right?
Yeah.
And then there's the ORP, which is the technology. Can the ORP only be done on your device, or could that be done in a current existing in-hospital lab? That's what I'm not clear about.
That's absolutely a part of the platform. It's the same software that we use to analyze our data can be used in a sleep lab as well. Absolutely. The key is the EEG, high quality, lab quality EEG coming from whatever acquisition.
So could a current sleep lab just buy the software and not buy your device?
Yes, I mean, it's rare to see a sleep lab be only in lab. The payers are definitely pushing the market to in-home. In fact, depending, I mean, as you know, the market's very fragmented, but depending on where you are, in some instances, level 1 labs require pre-authorization. So even labs that may not want to are adopting in-home technology, but I mean, you're talking of a reimbursement of $100 to $150 a study versus for the G code, we've seen reimbursement with hospital sleep labs in the $300 to $350 on the technical fee side. So they see this as an opportunity to get better information from the home and then also, you know, more profitability. Yeah.
Other questions? Yes. Oh, you're passing the mic. I can't see. Okay. Well, I want to push on that some more. I'm more confused now than I was when we were prepping. I'm not sure I totally understand the difference between selling this $12,000 device, and I understand what you said about trying to get folks at home. Are there two distribution lines? One is to the existing labs and one for something else, or am I getting am I mixed up here?
It's the same. It's the same customer. It's absolutely the same customer. The focus is on the complete product suite, and then obviously, you know, the ORP is new. That's where we want to talk about how do we actually add value to it. There's interest. It's a differentiator for the hardware, but the drive today is the hardware today and all of the healthcare economics that go with that, lower cost PSG in the home, better data. You know, even the old way of looking at it is better than just looking at sleep apnea and breathing. And then it's how do we add value to the ORP to differentiate our hardware and then actually get that software more broadly into the lab. So it's
okay. All right, and then I want to follow up the other question, because I know I liked in our prep and I like today when you show the slide with the two existing patients, two patients with the existing technology, both look essentially the same, and the ORP separates them. How robust a data set do you have on that? Is it published anywhere?
Like the validation data set?
The validation that the ORP is indeed more accurate.
Oh yeah, it's I mean, we did a three center study as a part of the FDA approval process. Our research team's actually in the middle of writing up, you know, in terms of publishing that work. But I mean, for anyone who wants to see it, like we've got that complete, whatever it is, 30-page report from the FDA submission. So our initial submission, as FDA goes, you know, they asked us to add some more diversity to the patient population. So we went back and added another 2 sites actually. So it's a very, very robust database showing equivalence to the type 1 in-lab data set.
Okay. So looking at your slide again, the primary issue that you would like to make progress on is reimbursement.
Yeah, the current state of the sleep market, the in-lab is type 1, the in-home is type 3, and then our study being a type 2, they all started out as G codes. The level 1 has been converted to full CPT. The level 3 has been converted to multiple CPT codes, but prior to, you know, a wireless self-applied system, the main way a PSG was done in the home is a patient would drive to the lab, get set up, drive home, or a technician would drive to your home with all the wires and set you up. So it was a completely inconvenient and extremely high cost. So the utilization of that code was quite low. So it's still there and it's starting to grow in popularity as new technologies are coming out. And that's the question of how do we help, you know, what are different tactics, strategies to stay engaged in terms of how do we get that, you know, converted into the CPT code? Is there, you know, just, yeah, different experiences around that, because it's a new area for us for sure. Yeah.
And my last question, I'll stop, go back to the audience. Is the interpretation automated, or is it you know, receiver dependent?
There's it's optional, you know, for it to score a sleep study, a full PSG manually by a technician takes, you know, 1.5 to 2 hours. Our technology, and that's the software subscription fee, automates that. So you get the automation of, event identification, the traditional stages, and then you also get access to the ORP technology. That will take that hour and a half to 2 hours down to, an average of 20 to 30 minutes. So still today, the standard of care is, reviewed and signed off by a technician. Yeah, so that's the automation on the scoring side.
Okay. Any other hands out there? Clarify again what the FDA is approving, has approved.
Like cleared, the FDA?
When they cleared, yeah.
Oh, the entire system, so the hardware and the software, the complete system has been cleared.
As a
by
class 2. So your label says this is for the, you're not making a diagnosis. This is a claim for measuring, right? For measuring.
Exactly. The
Observing,
indications for use
gathering
are
information.
providing information for a sleep physician to make it. Yeah.
Right.
Yeah. Yeah.
All right. Last chance if there are no other questions. Okay. Oh, yeah. Did someone say yes? It's like an auction here. No? Okay. Thank you, Patrick. I appreciate doing this.
And I really, look forward to next time. Really wish I could have been there. Thank you.
Great. That was a little harder. Fewer questions. I think the technical thing was part of that. In the prep with him, I found it pretty interesting, particularly on that slide where he shows the difference. So I hope we'll find some interest based on fewer questions that some of you will sign up to be the mentors. If not, we'll call on you and invite you, which we're not shy about doing. Anyway, I hope you all enjoyed this. Thanks. Yes.
So Tina leads our investment efforts at the consulate. So I just wanted to make sure that
Thanks. Welcome, Tina. You were so anxious to keep your remarks so short. You forgot Tina, right? Well, thank you all. Again, it's really nice to be together after 3 years. I very, very much appreciate your questions and participation.